Cardiac arrhythmias. So can someone tell me how they think about cardiac arrhythmias? And this is especially towards the MD2s and MD1s. Just unmute yourself. Tell me some things you know about cardiac arrhythmias and what is your approach in taking a cardiac arrhythmia history?
Yeah, so what I know about cardiac arrhythmias is, I was listening to Alex before, so there's sinus and like non-sinus. So non-sinus includes like, sinus includes like tachy and Brady cardia, and non-sinus includes things like atrial flutter, atrial fibrillation, also things like supraventricular tachycardias. How I sort of take my history is, one thing that's important is to determine like severity. So things like palpitations, things like syncope, whether it's exertional or not exertional. Those are three things that I focus on, but there's probably a lot more.
Yeah, that's very good. And thanks for sort of speaking up as well, Orican. So what I find is useful, especially for the MD2s, is that having a systematic approach to certain histories, for example, for cardiac, then you have your own sort of structured questions for your patients. So for example, whether they have any chest pains, because chest pains do occur with cardiac arrhythmias sometimes, and that is due to hypoxias, whether they have shortness of breath, whether they have syncope, whether they have lightheadedness. So those are all questions that you can ask. And certainly in this tutorial, I'll be giving some of the signs and symptoms that you should be looking out for the different conditions respectively. And I'll basically be writing a table up. So I think setting the basis for this tutorial, what I'm going to sort of have is that I want you guys to have a structure in thinking about cardiac arrhythmias. So I break my cardiac arrhythmias into 3 different categories. So my first one is my Brady and conduction abnormalities. Okay. And my second one will be my Svts. So my supraventricular tachyarrhythmias. Let me know if you can't read any of my handwriting, and I'll just repeat what I said. And my third category is my ventricular tachyarrhythmias. Okay, I probably shouldn't write VT. Ventricular tachyarrhythmias. Okay, so for the first part of the tutorial, we'll be talking about Brady and conduction abnormalities. Just let me work this thing out. I'm not sure how to scroll on the iPad. Yeah, we'll probably be rubbing things off a bit then. Oh, never mind. I got it. Okay, so let's talk about the category 1, which is my Brady and conduction arrhythmias. So the first topic I'm going to talk about is the sinus bradycardia. Can someone tell me what sort of rate are you looking at for a sinus bradycardia?
Less than 60.
Sorry, can you speak louder?
Did I hear less than 60? Is that what you said? Yeah, very good. So it's a ventricular rate of less than 60 beats per minute. And because of the sinus bradycardia, you would expect sinus rhythm. Okay, and normal looking P wave, QRS, T wave, but it's just that between every QRS, it's probably longer. Okay, it's not the best ECG drawing, but you get the idea. So when does sinus bradycardia occur? It's usually a normal response to cardiovascular conditioning, and that's why you can get it very commonly in athletes. But when it becomes pathological, it can occur in sinus node dysfunction or from uses of beta blockers or CCB access. Okay. And in terms of treatment for sinus bradycardia, management if asymptomatic and atropine. Now, what's atropine? Can someone quickly say what atropine is? It's an anti-muscarinic. Okay, so what muscarinic receptors do in the heart is that it slows down the heart. So if we use an anti-muscarinic, basically we're increasing the heart rate or decreasing the parasympathetic effect on the sinus node. So atropine to increase heart rate. Or if it's that severe that atropine doesn't work, we can then use a pacemaker. And this should be used with specialist input. And that's the definitive treatment. Okay, any questions on sinus bradycardia? Okay, I'll move on to the second page. Can someone see a blank page now? Okay. Okay, now we move on to the different heart blocks. First degree heart block. Why does that happen? Increased vagal tone. And it can also happen with beta blocker usage. Or again, calcium channel blockers, okay? So let me try and draw the Ecg finding. So it's just really hard to draw on the iPad. So can someone tell me, what am I looking for when I trying to diagnose first degree heart blocks?
Gradually increasing PR intervals.
Okay, so that's not for first degree heart blocks, no?
As much?
My primary, I
Yeah,
love
very
that
good.
it's categorizing them for us.
Yeah.
And then
Brenda, do you mind?
we know what first degree heart block is, but it's good revision.
Brenda,
PR interval.
Rihanna, do you just mind? Yeah, thank you. So it's defined as PR interval of greater than 200 milliseconds. So who can tell me how many small squares that is on an ECG piece of paper? You're looking for P, the R interval here. You're looking for this particular length to be greater than 5 small squares, okay? Each square is about 40 milliseconds. Anyone knows the management for first degree AV block? Alex? Management for AV block, first degree?
Would you go for like a positively chronotropic agent?
No. So it's actually a tricky question because you don't have any interventions. So you give them reassurance and you basically ask them to monitor their blood pressure, monitor their heart rate, and then you do follow-ups. Okay. Any questions on first degree heart blocks?
Okay. I guess if a patient were to ask, could this progress to something a bit more serious, like secondary degree heart block or any other kind of AV conduction issues? I guess from your personal experience, how would you kind of best answer that question to, again, reassure them and implicate their concerns?
Yeah, so usually what is sort of common is that they're usually on a drug that's either a beta blocker or a calcium channel blocker, which is causing the heart block. And we do titrate the doses quite a bit for that particular reason. However, if it's staying as a first degree heart block, and if the condition is chronic, then we usually don't alter the doses much. However, if it's progressing to a secondary heart block, then we choose to stop the offending drug. And in that case, atropine is then clinically indicated to boost sort of the heart rate up a bit. Okay. So second degree AV blocks are divided into two different types. Mobitz type 1 and Mobitz type 2. Who can tell me the difference between the two? Another name for it is Mecherbach. Okay. So the answer that I got before was that there's progressive PR lengthening, or I thought that was the answer. So this is actually second degree heart block with a Mobitz type 1 phenotype. So what you get here is a progressive PR lengthening until Qrs complex drops. Okay. And after it drops, the PR then resets. So if you're going to try and draw it, this is my P wave, QRS, T wave, P wave, QRS, T wave, P wave, QRS, until the QRS drops, okay? And then the PR interval sort of resets back to normal, which is less than sort of your 4 squares, 5 small squares. And as I said, the treatment for Mobitz type 1 is usually stop the offending drug and atropine as clinically indicated. Mobitz type 1. Whereas for Mobitz type 2, it is more significant because what you have here is unexpected dropped beat or beats without any changes to PR interval, okay? And up until now, the patient can be asymptomatic, and usually they are asymptomatic with Mobitz type 1, first degree heart block, and the sinus bradycardia that we've discussed. But for second degree AV block, Mobitz type 2, they can experience syncope, dizziness, and usually this is when a pacemaker is then indicated. Okay, so just drawing a line between two. Okay, and I think it's pretty important to actually understand a bit about the pathophysiology. So what happens with Mobitz type 1 is that usually it's from the drug effect as well.
Okay.
So what we've discussed about calcium channel blockers and beta blockers, or from increased vagal tone. But also it can occur in right coronary ischemia or infarction. Anyone knows why it's the right but not the left?
I'm just guessing, is it because the AV node is located on the right?
So you're on the right track. So basically what happens is the right coronary artery usually supplies both the sinoatrial node and the atrioventricular node. So we are more worried about rhythmic sort of conduction abnormalities with right coronary ischemias and infarctions as compared to the left. So the main worry with the left coronary artery, for example, left anterior descending artery ischemias, is that we have necrosis or ischemia or infarction of the myocardium. However, with the right, we're more worried about, first of all, sort of a feeling defect in that people can get hypotensive, and secondly is conduction abnormalities. So any questions with Mobitz type 1 and type 2? Oh, I forgot to say, so with type 2, the pathophysiology is usually fibrotic disease of conduction. And acute, subacute, or prior MI. Okay. Okay, now we'll move to third degree AV block. So with third degree AV block, another name given is complete heart block. And this, you do need a pacemaker. And this is the most common sort of condition where pacemaker is indicated. And anyone knows the definition of third degree AV block? So it's a complete
go for it.
No, go Jeff.
I'm just trying to let the MD2s have a crack, but it's just complete dissociation between the atrium and ventricles, I think.
Yeah.
As you're about to probably say.
Between atria and ventricles. Very good. So this is where patients can present with the signs and symptoms of syncope, dizziness, acute heart failure, or decompensated heart failure, hypertension, and Canon A waves. Okay, so that's an examination finding that you see on the JVP. So those are the signs and symptoms you're about to expect. And pacemaker, yeah. Any questions on third degree AV blocks? I'll just try and draw the ECG for you as well.
I'm going to go back to Mobitz type 1. You know how you mentioned that it can cause a feeling defect?
Yeah.
Like right coronary ischemia. What was the consequence of that again?
Oh, so what I was explaining was that in Mobitz type 1, it can occur with right coronary ischemias or infarction. So what happens is if in the so in MD2, you're always taught to give them nitrates, yeah, for myocardial infarction. However, a contraindication of nitrates or glycerol trinitrate is that if you're suspecting a right coronary infarct, you don't actually give the GTN. And the reason is because you get venodilation with GTN, and with right coronary infarcts, you have higher probability of conduction abnormalities, and actually you have a higher risk of filling defects. So patient can get hypotensive. So if you add a venodilator to the patient, they can be hemodynamically unstable. Does that answer your question?
Exactly, it does.
Okay,
Thank you.
sorry. Any other questions on third degree AV blocks?
Yeah, just another question for also the previous AV blocks. So from second degree heart block Morbitz 2 and third degree AV block, would you ever bother with atropine, or do you kind of just jump straight to the pacemaker?
Yeah, so very good question. So atropine is usually needed when the patient has bradycardia. And if they are severely bradycardic, you would add atropine regardless of their sort of rhythm patterns. However, with secondary heart blocks and third degree AV blocks, usually pacemaker is the gold standard. However, with symptomatic relief, if they say getting a heart rate of around 40-ish, you do add atropine as part of your temporary management. The reason why I haven't added atropine is that for these patients, the gold standard is to have a pacemaker inserted.
Yeah, thank you.
No worries. And the last one that the medical school doesn't teach you, or at least Melbourne Medical School didn't teach us, is sick sinus syndrome. Or another name is tachybrady syndrome. And what happens here, just for more space, is that it's a exogenous disorder which leads to intermittent Svts and bradycardias. Okay. So signs and symptoms. Secondary to tachycardia or bradycardia. So that by that, I mean the patient can feel that their heart is racing or their heart's sort of not beating as fast. So the symptoms can be related secondary to the tachycardias or the bradycardias. And other symptoms you may expect is syncope, palpitations, dyspnea, chest pain, TIA, and even stroke. Okay. And this stroke is not the stroke that you would expect, similar to an AF stroke, in that it's cardioembolic, but it's more sort of an ischemic type of stroke or an ischemic type of TIA from the bradycardia and the tachycardia, actually. And this is the most common indication for pacemaker placement. And you'll actually see it a lot in hospitals if you're on a cardiac ward. A lot of people who have sick sinus syndrome or tachybrady do get placement of pacemakers. Okay, so that's all for bradycardia. So we had sinus bradycardia, we have first degree heart block, second degree heart blocks, that's divided into Morbitz type 1, type 2, and third degree AV block, and 6 sinus syndrome. So those 1, 2, 3, 4, 5 conditions is all the Brady and conduction abnormalities that you need to know in terms of cardiac arrhythmias. Yes, we did, Jeff. And not sure why, but from memory, we didn't get taught it in the MD2 classes. No, yeah. Okay. If there's no other questions, I'll move on to the SVTs.
I have one question.
Yeah.
So to diagnose these, will you always get these typical findings on ECG, or will you need things like a Holter monitor and those kind of things long term to be able to diagnose it?
Yeah, very good question. So usually just a sort of a snapshot of an ECG in the ED department may not pick up the abnormalities, and usually in-home either Holter monitor or what they use in the ward. So for more long-term monitoring of their cardiac rhythms are the usual sort of gold standard diagnosis, at least in RMH, if that answers your question, okay?
So Holter monitoring?
Yeah, Holter monitoring, usually long-term monitoring, because, for example, with a 3rd-degree heart block, it may not be there all the time, and it might just be there sort of intermittently. And that certainly goes with the 6 sinus syndrome, and that people can have refractory periods where their ECG findings can be perfectly normal, and you just take an ECG shot of that specific time frame wouldn't actually help you in diagnosis of 6 sinus syndrome. So usually they're on Holter monitor, and even when they're on the ward, they're on constant ECG monitoring. Okay. Feel free to always ask me about questions that's backtracked. It's okay to disrupt it. It's not a very formal tutor, as you can see, but I just find that it can be a good way of remembering things, sort of writing it down. So now we'll move on to the SVTs. So there will be 7 conditions that I'll be talking about in the SVT. So I'll just write them down so that you have a list. So we're going to go through sinus tachycardia, atrial fibrillation, atrial flutter, multifocal atrial tachy, AVNRT, which is your atrial ventricular nodal re-entry tachycardia, or AVRT. An example of AVRT would be of Parkinson's White. And lastly, PAT, which stands for paroxysmal atrial tachycardia. Okay, so this should provide you a list with all the SVTs that is high yield for you to know. So we'll start off with sinus tachycardia. The sinus tachycardia is greater than 100 beats per minute. Sinus rhythm again. So patients can complain of palpitations and shortness of breath. Okay. And usually it's a normal physiological response to fear, pain, exercise. It can be secondary to hyperthyroidism, volume contraction, infection, or so one of the high yield sort of MCQ question from MD2 is that what is the most common finding that you would expect in a patient with PE? And it's not the S1, Q3, T3, it's actually a sinus tachycardia. So most common ECG finding is sinus tachycardia. And with management of sinus tachy is you treat the underlying cause. Right? It should be easy and self-explanatory. So with AF, which we will spend some time on because everyone loves AF, let's firstly go with the risk factors or the triggers of AF. So pirates is what people use a lot. And I like to add a C at the end as well. So P, anyone knows?
The PE.
Yeah. So I think about it as anything pulmonary. So if you have PE, if you have pulmonary fibrosis, anything that's disturbing the lung, you can actually trigger AF because you have a increased sort of a pulmonary either increased pulmonary pressures, or you have disturbance to the pulmonary matrix, which leads to the end organ damage of the organ previous to the organ that's damaged in the first place. So that's sort of the logic that I go with when thinking about the triggers. Secondly is ischemia. And by that, I mean you can get myocardial infarction and just a more diffuse hypoxic injury to the heart as well. So for that, on ECG, you would often get sort of a global picture of ST elevation. For example, acute pericarditis can lead to AF, and that's ischemia of the myocardium as a whole. So don't just think about sort of a localized artery ischemia, but ischemia to the whole myocardium. Anyone?
Would that be rheumatic heart disease?
Yes. Rheumatic heart disease. A. Anyone? Yeah, anemia. Very good. So there's a rare condition called an atrial myxoma. And in terms of physical findings, what does atrial myxoma give you? This is low yield, by the way. You don't need to know it for your med school. So it actually can cause clubbing of the fingers. Okay. And what's an important differential for atrial myxoma? Sort of your more infiltrative diseases of the heart. So also, I think in one of the prof reports that we had was Good syndrome. So you can search it up. Good syndrome can sometimes be present, and sometimes an anterior, sort of an anterior cardiac lesion can be confused with the thymoma, for example, in Good syndrome. Anyway, you don't need to know this. T stands for thyrotoxicosis. E, ethanol. S, sepsis. I'm just speeding up with because I realize I'm going a bit over time. C is always something that I add on is chronic AF. So triggers of AF, this is sometimes often missed. So one of the neurology consultant, Dr. Chris Dwyer at RMH once said, once an AF, always an AF. So if they've got a previous episode of AF, it's very, very unlikely that they will be sort of completely resolved from AF later down in the tract. So always think previous AF and chronic AF, okay? And also other chronic conditions, for example, hypertension and constrictive heart failure, congestive heart failure, sorry. And I assume you would all know that you would expect a irregular rhythm. Okay. And a lot of people actually sort of ignore these symptoms that comes with AF patients. Can someone just name a few of the symptoms that you may expect?
Palpitations.
Yep, palpitation. Any more?
I think
there'd be
MRO
shortness of breath.
So what was that? Jeff said amaurosis fugax, is that right? Yeah, so usually amaurosis fugax is an end organ damage as a result of AF. So you can get sort of a transient occlusion of the central retinal artery causing amaurosis fugax. But if you just have isolated AF without any cardioembolic consequences, it's unlikely to have amaurosis fugax. But with amaurosis fugax, definitely you need to put an ECG on them to check if they have AF as a risk factor to their cardioembolic sort of event. Very good. And what did you say, Alex?
I said shortness of breath.
Yep. And one important one is chest pain. So I actually didn't know that chest pain is very common from AF until sort of the cardiology I was with told me that actually one of the most important signs to look out for is chest pain. Actually, symptoms looked out for is chest pain. So people can just have chest pain from AF alone, and people may think that there's some ST elevation somewhere and over-investigate thinking that's myocardial infarction, but it is pretty common to see chest pain with AF patients.
I'm sorry, Jason, on a related note, would diabetic patients also experience chest pain due to AF?
So usually less so. I think the classic teaching is that sort of diabetic patients may get silent MIs. And the reason is because their sort of pain fibers, their A delta and even the C fibers is a little bit slow in terms of conduction, evoked potentials rather. So they are very variable in presentations. They may not even have chest pain as the sort of the main presenting complaint. You're right. So in terms of ECG findings, there shouldn't be any discernible P waves that you can see, and with variable irregular Qrs complexes. So for chronic AF, the initial management for chronic AF would be rate control with beta blockers, calcium channel blockers, what the drugs. So one thing I find with MD2, I'm not sure about Jeff, is that although we know a lot about AF, but when I actually go on the ward and see a patient with AF, I'm actually not too sure about why a certain drug is used or why they are on specific treatments that they're on. So I think this just provides you with an overall framework. Obviously, hospitals differ one by one, and sort of the protocol is different, and also depends on preferences of the consultants as well. But I'm just providing you with a general sort of list of things that can be used, and you can obviously sort of put your own flavor to it on the ward yourself. And we would anticoagulate, but does anyone know the consideration that we take into account when we do anticoagulate them?
If they have any prosthetic or mechanical heart valves?
Yes, that is one important consideration. Now, as an extension, does anyone know the target that we're trying to reach in terms of INR for different mechanical valves? So an INR target of 2.5 to 3.5 is indicated for aortic valve, okay, mechanical aortic valve. And with a mitral mechanical valve, it's usually INR target of 2 and 3. And just as a side note, there was an interesting case presented by Victor on, was it Friday or Thursday night? You can always check it out on the website. A very high yield topic, a very interesting case that he presented with, Alex, correct me if I'm wrong, but the patient also had, is it antiphospholipid syndrome or something else? But the INR targets are tweaked a little bit based on the other comorbidities the patient has.
Yeah, it was APS.
Yeah, so a patient with lupus presenting with sort of triple positive, I wasn't sure, but antiphospholipid antibodies, and discussion of the use of warfarin and the INR targets can vary depending on the patient. So as a general rule, definitely 2 to 3 is very commonly used, 2.5 to 3.5 for aortic valve, because they are the patients who are more predisposed to clotting and cardioembolic effects. So that's used as a general guide, but you always need to personalize it to the patient, is what I learned from that particular seminar. So another thing that I was trying to get at is the CHAD SPASC score. And you want them to be greater than or equal to 2. Does anyone know the CHAD SPASC score, or do you want me to sort of write them down as well?
I think it's important that we try to we learn this.
Yeah,
So,
yeah, no worries. I'll write it down, no problem. So you can always search it up, and I didn't really prepare this. So for people online, just check if I have it correct. Just remembering from the top of my head at the moment. So if they have congestive heart failure, it's 1 point. If they have hypertension, it's 1 point, which is a lot of the patients on the GenMed ward. So they already have 2 points now. So age greater than 75 is 2 points from memory. Is it 75, Alex? Can you check for me?
sure.
Diabetes is another 1 point. Now this is important. Stroke or TIA history is 2 points.
So yeah, age greater than 75 is +2, 65 to 74 is +1.
Yeah, cool. So a patient with stroke or TIA history, you would anticoagulate them no matter what other score they get. So this is pretty much the general rule to follow, because they are at an increased risk of further TIAs or stroke if the AF is uncontrolled and leads to any cardioembolic sort of events in the future. V from memory is vascular disease. That's 1 point. Age, as Alex said, 65 to 74 is 1 point. And last category is their female sex. That's 1 point. Okay. So that's the CHAD SPASC score. Anyone with any questions?
What did the V and A stand for again? Vascular disease and age, was it?
So what was the question?
So the V stand for vascular disease, right?
Yeah, vascular disease.
How about the second A?
The second A is also age. So
Okay.
65 to 74 is 1 point. However, if they're greater than 75 or equal to 75, they score 2 points.
The other thing that I have to point out is, you know how you were talking about rate control? Is it not true that rate control is generally preferred for older and asymptomatic patients.
Yeah, that is true. That's why I said sort of with chronic AF, it's usually rate control.
Yep.
Yeah, and also Jeff has mentioned in the chat. So 1 is rate, 2 is rhythm. So you would always sort of control the rate first, and then actually I'll talk about unstable AF as well, and then I'll follow on with antiarrhythmics and the different classes. So just bear with me a bit. So this is for your stable chronic AF patients. Usually it's rate control, beta blockers, calcium channel blockers, and digoxin. Just to be clear. So it's not for sort of your acute patients, it's not for your deteriorating patients, it's not for intermittent AF particularly, it's for chronic AF. All right, I'll move on to unstable AF. When you onset AF. And by that, I mean less than 2 days. Anyone know what we do with those?
I think if it's less than 2 days and it can be found that there's nothing in the antrum, no clots, I think you need a tow for that. So it's pretty rare to catch that, but then you can cardiovert instantly.
Yeah.
They worry about releasing a clot essentially if it's been building up for a while.
Yeah, very good. So cardiovert them if it's less than 2 days, because unlikely they're going to have a clot. But people do check it with TOEs or TEs, actually, transesophageal. Wait, that's the same thing. Transesophageal echoes. So if it's greater than 2 days or unclear duration, I'll say time, you must get a toe. Transesophageal, and anyone knows why transesophageal is preferred? To rule out.
It can see the clots in the, there's a spot in the atrium, I can't think what it's called, but whereas normal can't.
Yeah, it's a spot next to the pulmonary veins coming in. So to rule out atrial clot. So basically what they find is that the toe is best utilized to visualize the atrial region, especially the antrum that's coming from the pulmonary veins. Okay. And with atrial fibrillation, there are new sort of interventions nowadays where they can go through interventional cardiology. They can go through to the atrial appendage. That's the word. That's the right sort of area. So they can go to that area, atrial appendage, near the entry point of pulmonary vein to actually electrolysis that particular region, so that aberrant sort of firing of that particular area, which essentially causes the atrial fibrillation, doesn't exist anymore. And that's sometimes used as a definitive treatment for atrial fibrillation and atrial fibrillation that is uncontrolled with medications. But that's just an extension. Okay, so before we move on to the other arrhythmias, just say more about the antiarrhythmics. So there are 5 categories which I want to tell you about of antiarrhythmics that we use. Firstly is the sodium channel blockers. Secondly is your beta blockers. Third, potassium channel blockers. And fourth is your calcium channel blockers. Okay. So this 4 is commonly known, and there's actually a 5th category. This is classified as other, which is your adenosine, digoxin, and we can also give electrolytes. By that I mean potassium and magnesium. Okay. So I'm going to draw a graph, and I know you don't like this because I didn't like this particular lecture either back when I was in MD1. So this is sort of understanding how the electric potential in the heart occurs. Okay, so this is your stage 0 of your action potential when sodium, that's all good, Jeff. When sodium ions actually go into the cells, causing depolarization. And stage 1 is when your potassium and your chloride goes out of the cell. And your stage 2, and this is why stage 2 is actually pretty important in that it's the maintenance phase of keeping the electric potential positive, which is your calcium channel influx. And stage 3 is your potassium going out. Okay, so if you can imagine, if potassium is going out of the cell, then your cell becomes more hyperpolarized. And your stage 4 is your potassium rectifier channels. Now you may ask why I'm doing this. This is probably low yield, but it's pretty important for you to understand how the antiarrhythmics or the how the beta blockers actually work. So if we draw the corresponding ECG findings, that's your T wave. Okay. So if we draw the ECG findings, and as Alex said, sort of before the tute actually started, your class 1 and your class 3, your sodium channel blockers and your potassium channel blockers are usually used for rhythm control, whereas your class 2 and class 4 is usually used for your rate control. Okay. And how I think about this is that I actually go to the different channels, and I see how the drugs actually modify that particular channel to rhythm control or to rate control. So for example, with my class 1s here, let me just change a different color. So with sodium channel blockers, I divided into 1A, which is your moderate potency or moderate strength, if you like, rhythm controls. That's your quinidine, your procainamide. And procainamide is sometimes commonly used. And your 1B is your weaker strength antiarrhythmics, and that can lidocaine and phenytoin. Okay, now for those of you who've been in theatre, what local anesthetics do they use?
Lignocaine.
Yes, and why do they use lignocaine and not something else?
I know that it's a sodium channel blocker.
Very good. And?
I'm not sure about the other reason.
So think about this. Where do we inject the lidocaine? Or lignocaine. The lidocaine is probably the American version. So I've just been with a US plastic fellow, so I'm sort of used to his medication use, and I'm sure Alex is very used to this. But lignocaine, why is lignocaine used? And sort of tell me where it's injected to.
it can be used topically, I'm guessing. Like, for example, indwelling catheters, local anesthetics.
Yeah. So what I was trying to get at is if you look in theatres when we inject lignocaine, it's usually subcutaneous, sort of in that subcutaneous layer, right? So what if when the surgeon or the most likely the surgeon or the medical student is sort of injecting the lignocaine, and what if they actually got it into the veins? If I use something like a strong sodium channel blocker, like let's say propafenone, what would happen if that particular sodium channel blocker accidentally gets into the intravenous system? It would
But
actually
all feed into the right atrium, wouldn't it?
Yeah, it will get into the whole circulation pretty much. But the thing I'm worried about is that if it's a strong sodium channel blocker, it will actually affect the cardiac rhythms. So essentially you're creating sort of a cardiac arrhythmia by injecting the sodium channel blocker into the vein. So to minimize that, although sometimes it can happen, and even experienced, maybe not experienced surgeons, but even sort of qualified surgeons can sometimes inject sort of some doses of lignocaine into the smaller veins, especially with sort of plastic surgery. You can imagine the hand veins can be quite variable. So if the lignocaine is injected into the intravenous system, the effect of lignocaine is minimal in terms of its effect on the heart, if that makes sense. Okay, so that's just a side note, why we use lignocaine instead of other things for sort of your local anesthetics, okay? And continue on. By the way, if you guys are tired of sort of the tangents that I run on, because I do try and extend sort of just based on the cardiac arrhythmia topic itself, tell me and I'll try my best to sort of get back on track. So my 1C is my stronger sodium channel blockers, and that's your 9. Okay, and I do try to remember those because sort of that determines which agent I would choose in a sort of an atrial fibrillation if I want to rhythm control. So I probably wouldn't choose lignocaine for that sort of reason. Anyone knows the 2 cardiac specific calcium channel blockers? Yeah, very good, Ria. So you can see that why they're named 1, 2, 3, 4. It's based on this sort of similarly, sort of stage 1, although it's stage 0 actually, but it follows that order, sort of your the different stages of your cardiac depolarization and hyperpolarization. So your class 2, actually your class 4 is actually your calcium channel blockers, and they are your verapamil. And you deal to that. What's the other class of calcium channel blockers?
Dihydropyridines.
Yeah, dihydropyridines. Although not sort of not so much with those cardiac specific verapamil and diltiazem. Can someone tell me some of the side effects of dihydropyridine calcium channel blockers?
Are you referring to like the neuromuscular side effects?
No. So I'm assuming you're thinking about the calcium influx into cells releasing neurotransmitters. However, surprisingly, calcium channel blockers doesn't actually have much effect on the neuromuscular junction.
Is it related to like vascular resistance sort of thing?
Yeah, it actually decreases the vascular resistance and actually makes the sort of the vasculature more permeable. So a significant side effect you can get is peripheral edema. And also, I've heard a lot of consultants say that constipation can be one of the side effects of calcium channel blockers as well. Okay. Potassium channel specifically, I'm looking at two sort of agents, your amiodarone and your sotalol.
I think I'm wrong, but amiodarone kind of does a little bit of everything, right?
Yeah, it does a little bit of everything. That's correct. It also has effect on the parasympathetic nervous system as well. And your potassium rectifier channel, it's actually affected by your propranolol. I know it's a beta blocker, but it also has an effect on the potassium rectifier and your metoprolol. Okay, that's the cardiac arrhythmias. Sorry, the anti-arrhythmics that you need to know and how they work. All right. Any questions on atrial fibrillation? So just as a summary, triggers of atrial fibrillation follows the acronym PARTS. Symptoms, you can get palpitation, shortness of breath, and chest pain. Management differs considering if it's a chronic atrial fibrillation, intermittent, unstable, or new onset atrial fibrillation, but usually less than 2 days, you cardiovert them, and usually you do a checkup to see if they have an atrial appendage clot or any clot in that particular system. However, if it's greater than 2 days and sort of unknown time frame, then you usually wait on the cardioversion. You usually anticoagulate them first, and NOACs is sometimes used for that purpose. And in that period, they must get a transesophageal echo to assess for any atrial clots before cardiovert them. And the reason is that if you cardiovert them, there's a risk of delodging the clot into the carotid arteries, so to cause a stroke. And obviously amaurosis fugax, and not even amaurosis fugax, other visual symptoms can occur with a clot in the central, not in central, but in the cranial circulation, okay? And again, anticoagulation with warfarin is considered when the CHAS-VAD score is greater than or equal to 2, and the reason is the same, to minimize cardioembolic events. And from that, the different antiarrhythmics that we use is that with rate control, we usually go with beta blockers and calcium channel blockers. Calcium channel blockers specifically acting on the heart is verapamil and diltiazem. And beta blockers, sometimes we can use propranolol, metoprolol, depending on the physician. Lignocaine, we've talked about the different potency or the strength of different sodium channel blockers and why in the theatre as a local anesthetic, we usually like lignocaine over something more potent such as propofenadil. Does that make sense, everyone?
There's just 2 points that I was thinking of.
Yeah.
So in addition to the antiarrhythmics, there's direct electrical cardioversion.
Yeah.
And also maybe just the different types of AF, like persistent, long-standing, permanent, that kind of thing. Maybe just
sure.
those.
So for this particular two, I'm just focusing on the clinical significance, so the chronic and the unstable. I can certainly deal with the persistent and the intermittent on another tutorial, but I just want to keep today sort of more focused on the clinical aspect. Is that okay? Okay. Yeah, because I am just aware of the time, so we'll probably move on to atrial flutter. Okay, so anyone can tell me the difference between atrial flutter and atrial fibrillation?
Atrial flutter is like the regularly irregular, and it's known to have the sawtooth pattern on ECG.
Yeah, so I'll just draw the pattern for you. And it did come up in our MCQ end of year. So this is the pattern. So they're sometimes called F waves. I'm pretty sure it's a big F actually. So it's referring to the sawtooth appearance.
I actually saw a patient with AF earlier this week and did a long case on this patient.
Nice. Any other comorbidities that the patient has?
She seemed to have metabolic syndrome. So
Mm.
like she was on CPAP, she was obese. Even though her last glucose were okay, I suspect she was pre-diabetic as well.
Oh, okay.
Father had significant cardiovascular pathologies like heart failure, ischemic heart disease.
Yep. So with atrial flutter, circular movement of electrical activity around the atrium is what the pathology is. And usually they have a pretty fast sort of heartbeat of 300 beats per minute, of around 300 beats per minute. P to QRS ratio 2 or more. What do you mean by that?
So in atrial flutter, do you need P waves, like basically for every QRS, is it that you need 2 P waves or more for it to be atrial flutter?
I'm not quite aware of that, to be honest, from experience, but that can be the case. But usually they do see the sawtooth appearance, and you're quite right in that atrial flutter doesn't really occur if it's just one. And the reason is because if you have one P before the QRS, then it's just sinus tachycardia, if that makes sense. So you do sort of in thinking about it, you do sort of need 2P and the QRS for it to be regularly irregular, if that makes sense. Yeah. Any questions here? Well, let's go to management of atrial flutter. So again, anticoagulation, rate control, and cardioversion guidelines. Again, each hospital may differ in their protocol for cardioversion, in that there may be a different amount of period that the patient is on anticoagulation for before they cardivert, and different, for example, some hospitals may use apixaban, some hospitals may use rivaroxaban, some hospitals may even just go straight to warfarin before they cardivert. Okay, so management very similar to atrial fibrillation. And lastly, let's talk about multifocal atrial tachy. So I'll just give you the definition first. It's 3 or more distinct P wave morphologies. Has anyone come across multifocal atrial tachycardias before? So I'll just try and draw it. So that's your P wave. That can be your QRS, T wave, that can be P wave. And then you can get this weird spike here before your QRS. And then T wave, P wave. Okay, so and the passive pathophysiology for this is that multiple atrial pacemakers or reentrant pathways, okay? So if in your atrium, there are multiple centers of pacemaker cells, or if you have a re-entrant pathway, which we'll talk about with the atrial ventricular re-entry tachycardias, you can get something called a multifocal atrial tachycardia. And how it differs from the AVRTs and AVNRTs is that you need at least 3 different P wave morphologies. So for example, this one is different from this one, which is different from this one. So the P wave can occur either before I know it's a bad, but the P wave can occur, let's say, before the QRS, or it can occur with the QRS, or it can occur after the QRS. And there may be little spikes here and there, which signifies sort of your aberrant P wave conduction. And this happens when you have multiple foci of pacemaker generating capabilities in the atrium, or re-entrant pathways, which kicks off the P wave in different times, for example. And it's probably a very niche and specialist diagnosis, but I'm just thinking that it would be nice for you to be aware of the whole array of tachyarrhythmias. And funny enough, you can actually get it with COPD and hypoxia. Secondary to those conditions, you can get multifocal atrial tachycardias. So management, obviously refer to specialists, but you want to treat the underlying cause. Verapamil or beta blockers or rate control. And what else? That's pretty much it. Any questions on this very niche tachyarrhythmia? All right, we'll move on to AVNRT and AVRT. Okay, so this, as the name suggests, atrial ventricular nodal reentry pathway, it's a reentry circuit in AV node. Depolarizing atrium and the ventricle simultaneously. If I draw a conduction in your heart, you can imagine this is the right atrium. So if I have a re-entry circuit, sort of going like that, let me use a different color, re-entry circuit going like this, it can actually depolarize the atrium and depolarize the ventricle at the same time, leading to aberrant conduction, okay? With signs and symptoms, it's pretty sort of general. I'm sure you can get the gist of it now. So palpitations, shortness of breath, angina, syncope, and lightheadedness. Okay, and the same ones goes to AVRT. Rates about, as general, I would say about 150 to 250 beats per minute. And how would you determine it on ECG is that the P wave is usually buried within the QRS, or up here shortly after QRS. Okay. And management, I'll get to management a little bit later. I'll just explain what AVRT is different, how it's different. So again, it's in ectopic. Just change the color. Ectopic connection between atrium and ventricle. So instead of the AV coming down and going back and depolarizing the atrium and the ventricle simultaneously, what happens with AVRT is that there may be another conduction pathway which runs between the atrium and the ventricle, such that you have aberrant connection between the two, and you have a re-entry circuit like that. And symptoms similar. So in terms of ECG findings, I'll draw a Wolff-Parkinson-White ECG for you a little bit later, but I'll just give you what I have here, a retrograde P wave after QRS. And in terms of Wolff-Parkinson-White, which is an example of AVRT, is that you can get this. Does anyone know the name of this wave? Actually, let me draw this better. This is the QRS. Yeah, delta wave, very good. So this is the Qrs complex, and usually the Qrs complex can be widened, but it can also be normal as well. And this here is your delta wave. Okay, so you can see here there's not much gap between the P and the QRS in that it slopes upwards as soon as it sort of leaves the P complex here, and it slopes upwards. So this part is the delta wave that's sloping upwards, and then goes down, and then T wave. And one important thing to note is that atrial fibrillation or any tachyarrhythmias in Wolff-Parkinson-White is very dangerous. Okay, that's the takeaway with Wolff-Parkinson-White. And they are sometimes associated with other syndromes as well. For example, left ventricular non-compaction cardiomyopathy is one of the conditions that's associated with AVRT. And in terms of management, is the same between AVNRT and AVRT, which is cardiovert if they're unstable, or you can, if they're stable, use carotid massage, Valsalva maneuver, or adenosine to stop the arrhythmia. Okay. Any questions here? All right, I'll speed up. Next one is your PAT, which is your paroxysmal atrial tachy. Okay, again, you can experience palpitations, shortness of breath, angina, syncope, lightheadedness, just like your AVRT and AVNRT. Rates usually greater than 100 beats per minute. And the classical finding is that you get a P wave with an unusual access before each normal QRS. Okay, and the reason for this is because you have rapid ectopic pacemaker in the atrium that is not the sinus node. So what happens is with sinus tachycardia, usually the QRS and the P wave has a very sort of distinct length, and it has a very distinct phenotype. However, with paroxysmal atrial tachycardia, is that intermittently the P wave can have an unusual axis in relation to the QRS, in that it's very irregular, and in sort of a rate of greater than 100 beats per minute is expected. And in that case, with the management here, adenosine is often used as well. But it's also, adenosine is used diagnostically as well to unmask underlying atrial activity. Okay, so you can imagine if your heart's beating really fast, you can't really determine which one's the which one's the P wave, which one's the T wave. In that case, it's even more difficult to determine the axis the P wave is lying upon. So what we use adenosine to slow down the rate, to carefully look at the P wave in relation to the QRS. And to see whether it's, for example, if it's a bifid P wave, if it's an inverted P wave, if it's sort of a P wave that's very close to the QRS, for example, just to better assess its quality with adenosine, to slow down the rate before we can look at it more carefully. Any questions? So far, we've covered cardiac arrhythmias, including Brady and conduction abnormalities and supraventricular tachycardias. And if you can go back to the slide, now you should know the differences between sinus tachy, atrial fibrillation, atrial flutter, multifocal atrial tachycardia, AV nodal reentry tachycardia, AV reentry tachycardia, an example of this being Wolff-Parkinson-White, and paroxysmal atrial tachycardias. Now, with the last category, we have here ventricular tachyarrhythmias, which is, in my opinion, like in my experience, which is not talked about a lot in med school. Is that right?
Yeah, it's not as common a topic in terms of, I guess, cardio week from what I've experienced.
Yeah. I'm just trying to speed through it because I know it's already 11:30 and you probably want something better than sort of hearing my voice on a Saturday morning. So things I'm going to talk about is PVC, premature ventricular contractions. Wolff-Parkinson-White actually fits here as well, but I'm not going to talk about it once again because we've already discussed it in the SVTs. And the reason why it can be classified here under ventricular tachyarrhythmias, now you can all understand that with Wolff-Parkinson-White, it's an accessory pathway into the ventricles. So essentially, you can have a ventricular-driven tachyarrhythmia, if that makes sense, because of that re-entry from the atrium to the ventricles. You can now have an initiation of depolarization of the ventricles directly from atria to the ventricles through an unusual and pathological pathway. And once again, very specialist treatment of Wolff-Parkinson-White requires ablation of that accessory pathway, okay, to restore the normal pathway. And I'm going to talk to you about ventricular tachyarrhythmias, ventricular fibrillation, and it's important to know the difference between VT and VF because it can sometimes be asked in MCQs, and definitely knowing the morphology helps. And lastly, I'm going to talk to you, as I promised on the advertisement, Torsades de Pointes, which is a French word. So for any French audience here, I'm not sure if I pronounced it correctly, but usually ventricular fibrillation is sometimes subcategorized into monomorphic ventricular fibrillation and polymorphic ventricular fibrillation. And Torsades de Pointes is also another name for polymorphic ventricular fibrillation, but I'm just sort of separating into two for sort of management sake, because they do differ in management. And I'm going to draw you the morphology of each. I'm going to try and draw it, and then I'm going to tell you a little bit about the management. However, if a patient comes in with ventricular tachyarrhythmias, usually the consultants or the specialist ED physicians will be involved. So it's not a decision on your own. Okay, so I'll try and finish it in another 10 minutes. PVC. Premature ventricular contractions arises from ectopic beats in the ventricles, as the name suggests, as the session suggests. Associated with, so risk factors can include hypoxia. Now, electrolytes is very important in ventricular arrhythmias, and you'll see later on. And hyperthyroidism. And as a workup for every arrhythmias, hyperthyroidism should always be in your differential list. So patient can be asymptomatic. And even, sorry, did I just lose this? Oh no.
Can you undo?
There it is. Asymptomatic. What was I saying? Okay, yeah. So patient can be asymptomatic, and it can be an incidental finding. In that case, you don't need to do much. But if they do become symptomatic, they can get palpitations and sometimes shortness of breath. Okay. And I'll just try and draw it for you, although I know I'm not a good drawer. Curious. Now, what do you notice here? So these are my ectopic beats in the ventricles, okay? So do anyone know what the length of the Qrs complex is in a normal person?
3 to 5 Qrs complex.
Yeah, three to five small squares. If it's greater than, actually, I would say if I see a Qrs complex greater than 3 small squares, I would be alert and see if there's any ventricular abnormalities. So you can see here there's a widened QRS that is not preceded by a P wave. So there's no P wave here. And usually what you get is that with a PVC, usually it's followed by a compensatory pause. So you actually don't get a QRS after a PVC. However, you may get QRSs after a PVC sometimes. So it's not a definite, but you don't be surprised if you see a compensatory pause after a PVC occurring, because it can be pathognomonic for premature ventricular contractions. And usually the contractions don't follow a P wave. And with management, you treat the underlying cause, whether that's hypoxia, electrolytes disturbance, or hyperthyroidism. And if they have symptoms, so if they have palpitations or shortness of breath or dizziness, give them beta blocker or antiarrhythmics. So your sodium channel blockers or your potassium channel blockers. Okay, so that's PVC. Okay, now get a new page.
Can I just clarify? Did you say 3 small squares for the heights or for the width of the QRS?
Width of QRS.
Okay.
So
Is the height also higher?
No, height's not a major concern in arrhythmias, actually. So usually height we look at more sort of specifically for hypertensions and even acute pericarditis. So when you have low voltages across all leads, then it's suspicious for acute pericarditis when you have compression and the conduction system doesn't occur in such a way to create the hypertensions normally. Or you can get in chronic hypertension patients, hypertensive patients with left ventricular remodifications, in that there is left ventricular hypertrophy. In that case, from memory, you can compare, I'm not sure, I think it's V2 and V5, and you look at the positive deflection, positive depolarization and the negative hyperpolarization of those leads. And if it's greater than 7 large squares, you can diagnose left ventricular hypertrophy from that. And there are different criteria for the diagnosis of left ventricular hypertrophies on the basis of the height of Qrs complexes. Does that answer your question, Aiko?
Yes, thank you.
Yeah. All right. It appears that I have reached my maximum whiteboard numbers, so I'm going to go back to a few slides and just maybe squeeze in. So I'm going to squeeze in here and tell you about VT and BF. So VT. Risk factors. Is your sort of your cardiac diseases, your MI, and your structural heart diseases. And usually a non-sustained, why is it so thick? Non-sustained VT, and that is less than 30 seconds, is usually asymptomatic. And the sustained VT, e.g. greater than 30 seconds, you can have palpitations, hypertension, angina, syncope. Why do you have hypertension? Because you get aberrant filling as a result of ventricular tachycardias. So as you can all remember to your first year physiology, the filling of the heart is important to pump the blood around the circulation, the peripheral circulation, that is. So if you have aberrant contraction from ventricular tachycardia, before each cardiac output or cardiac beat, your ventricles aren't filled to its maximum capacity. So basically you're pumping out blood at a faster rate, however, before the ventricles can fully fill. Okay, therefore you actually don't get enough cardiac output per beat to go around. Sorry, stroke volume per beat to go around, therefore decreasing cardiac output. Okay, so the Ecg finding, try and draw it here. You get something like this. Can everyone see this?
Yep.
So it's very consistent. However, you can notice it straight away that it doesn't look like normal ECG. And another definition for VT is that it's greater than 3 or more consecutive PVCs. Okay, so remember we talked about PVCs, premature ventricular contractions. If you have 3 consecutive PVCs and they are all wide QRSs, and they occur in a regular rapid rhythm, and you get VT, okay? And you see AV dissociation as well. So, management, cardioversion, and the antiarrhythmic that you use here, sorry about my spelling, it's very bad, is amiodarone, lignocaine, or lidocaine, procainamide. Okay. And let me just go back to this for BF. Again, it's associated with cardiovascular diseases. And sorry, just another 5 minutes, then we'll be done. Structural heart disease. And what's dangerous about VF is that you can actually get cardiac arrest plus asystole. So presentation, syncope, absence of blood pressure, and you can get asystoles. So no pulse pretty much. And I'm really good at drawing this. So this is ventricular fibrillation. And here is immediate electrical defibrillation. And ACLS protocol. Okay. Any questions with VT and VF?
What does ACLS stand for?
Oh, that is a good question. I never asked myself this. Maybe search it up. Sorry about that.
Advanced cardiovascular life support.
Yeah, so it's basically your chest compressions, your what you learn during those first aid what do you call it? First aid workshops, where you put the defibrillator on, you do cardiac compressions, you do breathing, those sort of stuff. Yeah. Okay, lastly, I'm just going to find a blank-ish piece of paper and just write here Torsades-de-Pointes. Torsades-de-Pointes is actually just a form of VF, but it just sounds nice, and it just seems that our tutorial is actually very difficult, but it's actually not that difficult. It's associated with long QT syndrome. And do search up what causes long QT syndrome. So you'll find a lot of the antibiotics, antidepressant, antipsychotics can cause long QT syndromes. It can result from hypokalemia. Again, we can have another session on the clinical manifestations of hypokalemia and hyperkalemia if you guys want. Congenital deafness and alcoholism. Okay, and it can present with sudden cardiac death, typically associated with sort of your normal shortness of breath, dizziness, syncope, as most of the other cardiac arrhythmias do. But this is very dangerous in that you do get something like a VF as well.
Can I just ask a quick question?
Yes.
Isn't Torsades-de-Pointes a form of VT, not VF? Or am I mistaken there?
You might be right, actually. Just let me think. Polymorphic. Yeah, you're right. Polymorphic VT. Yeah, that's correct. Yeah.
Okay, cool. Thank you.
So polymorphous, polymorphic. Yeah, VT, sorry. I even have it on my notes here. VT. So it's basically, you can think about it is it's VT, however, it's not as erratic as your ventricular fibrillation, but it's a ventricular tachycardia with rates between 150 to about 250 beats per minute, and it is polymorphic. Okay. Does anyone know what's the management of torsade de pointes is? In other words, what would you give them? Yeah.
Electrolytes.
Yeah, IV magnesium. Very good. IV mag is what you want to give them initially as a bolus. Cardiovert, if unstable, once again, similar to my VT management. And you want to correct the hypokalemia. And remove any offending drugs, whether that's your antipsychotics, antidepressants, or antibiotics. Okay, so that is all I have for you on cardiac arrhythmias. So just a recap on sort of your ventricular tachycardias. We've gone through premature ventricular contractions, or Parkinson-White we've talked about in this SVTs as well. Ventricular tachycardias, monomorphic and polymorphic, which is your torsade de pointe, and your ventricular fibrillation, in that you need the ACLS protocol and you need defibrillation for ventricular fibrillation. So I'm not sure, can you see my 12 sort of whiteboards here? So I will upload somehow to the website my drawings, and obviously I feel like those tutorials are the best if you can just just tune in, ask those questions, and I do want a general feedback as well. Just people can just unmute yourself and just let me know how you found this session. Was it useful, and are there any sort of modifications that I can make possibly for the headache tutorial next Saturday?